Hello everyone, welcome back to my channel. So today we'll be discussing about hypertrophic cardiomyopathy and more importantly its echocardiographic evaluation. So first, let us understand what is hypertrophic cardiomyopathy. It is the most common genetic cardiac muscle disease caused by a mutation in sarcomere protein genes which encodes for elements of the contractile machinery of the heart. It is characterized by an increase in left ventricular wall thickness, that is why the term hypertrophy, which further causes left ventricular outflow obstruction, diastolic dysfunction, myocardial ischemia, and mitral regurgitation. Moreover, HCM can be obstructive as well as non-obstructive. 2D echocardiography is one of the most commonly used clinical investigations in order to further assess HCM. So now let's discuss all the echo parameters that are used to assess HCM. As you can see, there are total 7 echo parameters that we use in daily routine examination of HCM, which now we'll be discussing one by one. So the first one is confirming the presence of LVH. Hypertrophy can involve any region of the myocardium, including increased wall thickness confined to the apex or the involvement of LV free wall or even RV. Evaluation of the pattern and the extent of LVH is made from multiple tomographic 2D image planes and include the measurement of maximum wall thickness in all the LV segments from base to apex recorded at mitral, mid and LV apical level. So the Plaque's view is best to define the exact relationship between the pattern of septal hypertrophy by measuring the septal and the posterior wall as well as to assess the outflow tract. The short axis view helps in the assessment of systolic obliteration of LV cavity at apical level as well as helps in the confirmation of LVH at basal and mid level. Apical 4-chamber view along with color and pulse wave Doppler helps in the assessment of gradients at LVOT, LV mid cavity and apical cavity level. So here is a demonstration of apical 4-chamber view in which the thickness of mid-inferoseptum and anterolateral wall is measured. Similarly, the maximum wall thickness of all the other LV segments should also be taken. So our next parameter is assessment of LVOT obstruction. But before moving further, let us first understand the classification of HCM on the basis of obstruction. So HCM can be non-obstructive, obstructive or provocable. In non-obstructive HCM, the LV outflow gradient at rest or on provocation is less than 30 mm Hg, whereas in obstructive HCM, the gradients at rest itself is more than 30 mm Hg. In provocable HCM, the gradients at rest are less than 30 mm Hg, but the obstruction as well as the gradients increase with exercise. All the LV intracavitary gradients are usually measured using Doppler echo. Doppler studies provides a more direct evaluation of the presence, location and degree of dynamic subaortic obstruction. Using pulse wave Doppler from an apical approach, the sample volume is slowly moved from the apex progressively towards the base, recording the velocity curve at each step. This stepwise calculation using pulse wave Doppler is advantageous in the intracavity gradients due to apical hypertrophy. In about 70% of the patients with HCM, subaortic obstruction is present at rest or with exercise and is characterized by mid-systolic closure of the aortic valve, fibrotic changes at the level of leaflet septal contact, and coarse systolic fluttering of the aortic valve. Now let us see some real-life 2D echo images for our better practical understanding. As you can see, this is a Doppler at the LVOT level and we can clearly identify the dagger-shaped pattern. In the second image, the pulse wave Doppler is kept at the mid-LV cavity level and the gradient is around 30 mm Hg. The third image measures LV apical cavity gradient which is around 10 mm Hg. Next, you can see the mid-systolic closure of aortic valve on M mode, which further confirms the presence of subaortic obstruction. Our next parameter is one of the most important sign which confirms the presence of LVOT obstruction, and that is systolic anterior motion of the mitral valve. SAM is defined as systolic anterior motion of the mitral leaflets into LVOT resulting in turbulent flow, appreciated as mosaic pattern by color flow Doppler. In SAM, the tip of AML typically develops a sharp and superior angulation leading to mitral leaflet septal contact in early to mid-systole. Severity of SAM can be graded on the basis of AML and septum contact as shown. Here is a visualization of how SAM can be easily identified using M mode. The next parameter is LV systolic function. In patients with HCM, the LV systolic function is usually normal or higher. For this, tissue Doppler imaging should be performed at basal inferior septum and anterolateral wall routinely in all HCM patients. Mean systolic velocity of less than 9 cm per second is a parameter differentiating pathological LVH from physiological LVH, whereas low lateral mitral annular systolic velocity of less than 4 cm per second was found to have higher prognostic value. The next parameter is LV diastolic function. Patients with HCM often have a pattern of LV diastolic filling consistent with impaired relaxation regardless of symptoms or presence of LVOT obstruction. Typical changes include reduced E velocity, enhanced A velocity, prolonged IVRT and DT, increased duration of velocity of the pulmonary vein reversal, increased PASP and LA volume. LAV of more than 34 ml per meter square has been shown to have greater degree of LVH, severity of diastolic dysfunction and adverse cardiovascular outcomes. As you can see in this mitral inflow Doppler that the E wave is less than the A wave and the DT is prolonged. The next parameter is RV hypertrophy. One can always look for RVH or any RVOT obstruction. Assessment of RVOT gradient can be done in short axis view at aortic level. Last and one of the most important parameters is the assessment of mitral regurgitation. The mitral valve is anatomically and functionally abnormal in majority of patients with HCM. Anatomically, the leaflets are larger than in normal people. Functionally, MR results from SAM of the leaflets into LVOT leading to late systolic failure of coaptation and as a consequence posteriorly directed MR jet. MR severity typically is moderate but ranges from mild to severe and varies dynamically with the severity of outflow obstruction. And that is all about HCM. Thank you so much for watching. Do like and share the video and don't forget to subscribe.